You talk a lot about statins. I talk a lot about statins. We talk about cholesterol. I understand that you've got some newish information on statins, because one of the main problems I have with statins is that the drug companies will not release the raw data from their studies. We just have to blindly trust them that the study was properly designed, that it was properly conducted, and that they got the numbers they actually said they got. And I understand that you've got a little bit of insight on that situation.
I mean, this is a complete debacle. I mean, the fact is that you and I, as independent doctors, independent researchers, do not have access to the raw participant level data on statins. It's just astonishing that we have to accept at face value what these pharmaceutical companies, who have this obviously desire to increase their profits. So if we go back to, we all know about the Oxford University and Sir Rory Collins and, all of that. But in 2013, there was the Cochrane collaboration did what's called a systematic review on statins. And they said, we found in some benefit, but they acknowledged the possibility that perhaps if they had access to the full data, that are unpublished data, that perhaps their results might change. So in 2012, there was an agreement with drug companies around the world for them to provide access to unpublished data. So two authors from the Cochrane collaboration, they actually approached drug companies and they made 10 submissions using these convoluted approaches to drug companies to say, look, can you please give us your unpublished data? So obviously, statins are a wonderful drug. You know that, we know that. If you give us the unpublished data, we'll be able to tell the world the convincing truth. So of these 10 submissions, 2 companies didn't respond. Flat out didn't respond, so much for an agreement. Then we had AstraZeneca. They declined on the basis of their internal company policies, which makes me wonder how the company was able to make this agreement. Pfizer, we may have heard of Pfizer too, they said, I would love to, but we actually didn't collect any data on the side effects of our drugs, of the statin. Sorry, I'm not talking across their whole product range. That would be speaking out of turn. Other companies, they said that the statin data was collected before they formed the agreement. Therefore, it doesn't form part of the agreement. In another situation, the company said, the period where we're required to retain the data for the statins has lapsed. So presumably they just burnt the data rather than having it be released transparently. A Japanese company, this is very interesting, the one that was researching the very first statin, Sankyo, they actually specifically excluded statin data from the drug sharing agreement, almost like they had something to hide. Now, the really interesting thing is that this company was actually in a race with Merck to develop the first statin back in the 1970s. And it's on record, there is some documentary evidence that they stopped researching the first statin because it was causing too many cases of cancer in their test animals. And gee, it would be wonderful if they hadn't excluded that data from this data sharing agreement, wouldn't it?
Yes, that would be very nice.
I mean, wouldn't you love to have your hands on this data? But the simple fact is, we say we've got all of this data, and this information was something that unfortunately I didn't have room for in my lecture, but I probably should talk about it. I'm glad that you've given me the opportunity to talk about it publicly today. But the fact is that the drug companies do not give us access to all the data on side effects. And even when they do give us data, the data that they curate, that they want us to see, the benefits on statins are marginal at best. Now, technically they are there in the matter of, it might increase your life expectancy by 3 or 4 days. But, would those benefits vanish if we had access to the full data? And that's a question we don't have the answer to. But in my head, I think I know what the outcome would be.
Yeah, me as well. And so the 10 companies that are responsible for the majority of statins on the market, either just didn't reply at all or said, no, you can't have that, or we've destroyed that data. Even though much of this data, many of these studies were actually paid for with government dollars, aka
on the public dime. Yes, right? Exactly right.
But yet somehow they own the data, even though it was paid for by the people.
And not only that, understand that we're wanting data on personal individual side effects. We want to know what happened to Mr. Joe and Mary when they took the statin. Did they get muscle aches? Did they start weeing blood? Did their liver start, cooking itself? So this is individual data.
Yeah, it's crazy. And speaking of drugs, statins are very often part of a pharmaceutical soup that patients, especially over the age of 50, they're going to be on a statin, 2 blood pressure medications, 2 diabetic medications, medication for restless leg, a medication to help them get to sleep, a medication to help them stay awake. Polypharmacy. Now, I know you have some rather strong opinions about this, and most of them align very closely with my beliefs. Listen, I used to be guilty of this, Dr. Mason. Let me be the first to fess up. Early in my career, when somebody would come to me on 5, 10, 15, 20 different prescriptions, and they'd be like, yeah, I'm just here to get labs and get my refills, I would refill every single medication. I never went down line by line. Do you still need this? Do you still need this? I never did that. It never occurred to me to do that. I thought my job was just to refill everything. I'm not joking. I'm serious. Yeah. And now I would never in a million years do that. If somebody came in on 20 medicines, they would walk out with at least 9, if not 15 of those medicines canceled. Right. And so
if we were to sit down together and say, well, let's take a root cause approach to medicine. Now, what does root cause mean? It's saying find out the cause of disease and address the root cause. We've either got a root cause approach or we've got a Band-Aid approach, which we call a pill for every ill. Oh, you got a headache. Oh, you don't sleep well. What have you? Now, if you and I were to sit down and put our heads together and come up with a list of medicines that would genuinely be root cause medicines, it would be less than 20 medications, I would imagine. Would have anti-infective agents. You might have hormonal therapies for people who have had a damaged gland, like their thyroid gland might have cooked itself and they need thyroid hormone, or they might need testosterone or something like that. They might even need insulin. But the list would be far, far shorter than what we're actually able to prescribe. Most drugs actually just treat symptoms. So what I presented on recently in a lecture called Fixing Medicine was a case of egregious polypharmacy. So there was a 71-year-old lady, and she was found to have slightly high blood pressure, which, by the way, have you ever gone looking for the all-cause mortality benefit of blood pressure medications, like for evidence that they actually make people live longer?
Well, for minimally elevated blood pressure, it's infinitesimally small.
It's an unsatisfying search. So anyway, so this lady was started on she had blood pressure that was elevated, so she was started on a blood pressure drug. Now, this particular drug is called a calcium channel blocker, amlodipine, and it is known to have a side effect of ankle swelling. And as you know, ankle swelling can also be a sign of heart disease, or a drug side effect. Surprise, surprise. So she ended up seeing another doctor who said, oh, you've got swelling of your ankles. Well, you must have too much fluid in your body. Let's give you some fluid tablets. These are called diuretics. They force the kidneys to expel extra water from the body, basically leading to a state of dehydration. Now, if you put an old lady on 2 diuretics, you can reliably predict she's going to start peeing. And guess what? She did. So she was diagnosed with urinary incontinence. So she was put on another drug for the urinary incontinence. Now, this drug has what we call an anticholinergic side effect, which leads to the sense of a dry mouth. And that was bothering her quite a lot. So she was given a drug to treat this, which is lovely. But eventually she ended up being on 17 separate drugs, including all these ones that were commenced in rapid succession, including 2 antidepressants and an antipsychotic drug, most of them which have falls risk as a side effect. Can you guess what happened? She fell over in her bathroom, struck her head on the basin as she went down and fractured her spine. Now, the interesting thing was that 2 days ago, I was seeing a gentleman who was in quite a pickle last year. He came to see me and he was in quite significant heart failure. His lungs were full of fluid. His legs, he had, fluid pitting edema up to his wazoo. He really wasn't in good state. And he embarked on what you and I might call a proper human diet. He's lost 20 or 30 kilograms in the last few months and he's in a much healthier state. And I just saw him a couple of days ago and I said, how are you going? He goes, I had a fall. I said, oh, you tripped over? And he's like, no, I fell. I just fainted. I had a look at his drugs and he was on 2 diuretics and 2 different blood pressure medications. And I just think, oh no. And it's like, once you get healthier, we need to take you off of these drugs. These drugs are causing side effects. And he went to an emergency department. They gave him a full cardiovascular workup. They said, sorry, buddy, we don't know why you fell. See you later. Did nothing. And it's very clear that he's on multiple drugs that are causing increased risk of falls. And I suspect that if we appropriately change his drugs, as in deprescribe, which, as you know, we're never taught how to do,
Right.
It's always makes us feel uncomfortable because we're never told to deprescribe. We're never taught how to do it. But if he goes through an appropriate process of deprescribing, his chance of having another fall will be way down.
Absolutely. And my heart goes out, the poor woman on 17 different medications. People think, well, that's probably a special case, probably very rare. That is so common in people over the age of 50 or 60 or older. That is so common that now doctors are actually writing books about pharmacology and deprescribing. Finally, but
it's harder than you think.
It is. It's not easy, especially for some drugs. It's a very touchy thing to do it too quickly. And so I'm glad there are books about it. But you're right. As a young doctor, I never thought about stopping a medication. I didn't think that was my job.
Well, let's take proton pump inhibitors, so an acid reflux medication, right? So incredibly commonly prescribed. So when I was in medical school, we basically got told, safe as houses, as long as you want, suppress the natural acid secretion in the stomach, that you can risk becoming deficient in a lot of electrolytes, calcium, magnesium, so on and so forth, which is why you have an increased risk of osteoporosis, increased risk of community-acquired pneumonia because of aspiration risk, increased risk of dementia because you reduced absorption of B12.
And so in the United States, this would be Nexium, Prevacid, Prilosec. Those are probably the biggest 3, and there's a couple more. Go ahead, doctor.
So they're just awful drugs long term.
Yes.
And if you have a look at the prescribing information, and the thing about prescribing information is that by law that has to be accurate. Otherwise, those execs could go off to jail. So that little leaflet inside the drug box, that's the holy grail for accurate drug company prescribed information, which is I love sometimes, which is why when you look up on Crestor, you'll see it causes diabetes and so on and so forth. But that's another side tale. But these side effects of these proton pump inhibitors are huge. And the problem is that if you suddenly stop them, you will get a side effect. So they took a bunch of volunteers and they said, here, take this drug. And then and these volunteers were healthy. They had no reflux before they started. Then they stopped. 40% of them developed symptoms of reflux. So this is called rebound acid hypersecretion. So what happens is by taking this drug, you suppress the natural acid secretion of the body, and the body says, I need the acid. So it dials up the acid production to counteract the drug. So if you suddenly take the drug away, you take off that brake, you're going to have a lot more acid being produced. And this is why when people inappropriately, they may appropriately, but usually inappropriately get prescribed one of these proton pump inhibitors, when they try to stop it, they get the reflux and I still need to take it. They end on it indefinitely. So you actually have to wean off these drugs quite slowly. You start halve it again, do it second daily, however you want. And I usually, have a protocol over, 2 to 6 weeks, depending on how long they've been on it, where we actually get to wean them off. But you think we're taught how to do this in medical school?
Nope.
Not in your life.
Nope. And for many people, when they begin a proper human diet, whether that's low carb, real whole food, or ketogenic, real whole food, or ketovore or carnivore, wherever you fall on the proper human diet spectrum, most people with chronic heartburn, their heartburn gets substantially less severe. And so we've had so many people in the private community be able to come off of these. But if they come off them too quickly, they're like, oh, I just stopped it cold turkey. I had the worst heartburn I've ever had in my life. I got back on it. Then I have to have this conversation with them. You got to do it slowly so you don't have the rebound acid reflux.
Well, do you know Dr. Eric Westman?
Sure.
So I believe he did a study, as a bit of an older study, and I don't think enough is made of it, where they actually did esophageal probes. I think it was Eric, I hope it is, esophageal probes, and they were measuring the acidity in the food pipe. There's not meant to be acidity in the food pipe. And they actually found that when people went on low-carb diets, they had a significant reduction in the acid levels of the food pipe, the esophagus, within 6 days.
Yep.
And interestingly, I've actually delved into the mechanisms of this, and a lot of it is not so much the low carbohydrate element, but the low grain element, because with the grains, you can get what we call lectin cross-linking of IgE, which leads to histamine release, which leads to acid secretion. So it's actually, there is a mechanism by which grains, because they contain these carbohydrate binding proteins called lectins, that will actually specifically induce acid secretion. So it's nice. We've got the biological mechanism, and we've got the experimental proof that when you go on a low carb diet or you cut some of that crap out of your diet, very, very rapidly you get improvements.
Yeah, and we see that all the time. One of our community members has a question. What are your thoughts about the PCSK9 inhibitors? In the United States, this would be Praluent and Repatha are the two most common brands.
Right. Well, they're very effective at lowering cholesterol.
Yeah.
Damned effective. Here's the thing. Is cholesterol essential for life? I don't know. Okay, well, that's one conversation. Here's another question. Have they ever been proven to statistically significantly extend lifespan? So I ask patients, when patients come in on a drug, I like to ask them why. And they usually have no idea what I'm getting at. And I'm saying, well, they say, well, I'm taking it because my doctor told me to. But why? Why are you taking it? And we get down, what I want them to say is, I'm taking it because I think it will make me healthier. I think it will help me live longer. I can enjoy a longer retirement and see the grandkids grow up. You know, I want a mortality benefit. Yep. So, and mortality is one of those fabulous markers that is very difficult to fudge. Even a disingenuous, dishonest researcher has a hard time saying that somebody's alive when they're under 6 foot of dirt.
Yes.
So it's a brilliant endpoint because it's accurate, it's objective. So if we actually we don't worry about surrogate markers like cholesterol, but we say, well, you know, when we give you this drug, do you actually live longer? That's proof that that will be offering you some benefit. And to my knowledge, there's not been a single study that's proved any mortality benefit for the PCSK9 inhibitors. Now, this probably segues, if I may hijack this a little bit, into a conversation on cholesterol. And I often see this, there's two schools of thoughts in the carnivore community.
Yes.
There's a school that says cholesterol, it can be as high as you like, it's never going to be a problem. And there's this other school says, oh, I want to have a bet in each camp. Look, I don't think cholesterol's bad, but everybody else says it is, so I still want to take a statin. I want to lower it. And I think the truth is somewhere in the middle. Now, what do I mean by that? So if you've got high cholesterol, we can determine whether you're likely to derive a mortality benefit or a survival benefit from taking a statin by looking at something called your triglyceride to HDL ratio. And if you've got a good triglyceride to HDL ratio, that means low triglycerides, higher HDL, then the data very clearly indicates, and this is drug company owned data, which in an article with Ben Bickman and David Diamond, we did a couple of years ago, we very clearly made this, demonstrated this using drug company owned data, that you don't get a mortality benefit from taking statins. So we can assess high cholesterol level. First thing to do is to assess the triglyceride to HDL ratio, you know, and if you've got a good ratio, then there's really no reason on God's green earth why you would need to take a statin. But that doesn't mean that the cholesterol is fine, because there are, if we actually have a look at the all-cause mortality curves, we see this little U shape. And we know that when people's cholesterol goes too low, their chance of dying significantly increases. But also, and to a lesser degree, lower gradient, but still exists. When the cholesterol is very high, there does appear to be a statistically significant increased risk of death. And then I believe the reason for this is because cholesterol production does associate with other health-related parameters, such as nutrient deficiencies and chronic inflammation. For example, if any of your listeners out there want to do a quick internet search, just type in B12 deficiency and cholesterol, and you'll see that there's very clear evidence that B12 deficiency increases the biosynthesis of cholesterol. There's other factors that can increase cholesterol as well, a folate deficiency. What about an underactive thyroid? What about a condition, we call it hemochromatosis, a genetic tendency to overabsorb iron? It doesn't have to be full-blown hemochromatosis where you've got 2 affected genes. You could be heterozygous and just have 1 affected gene. That also will affect your cholesterol levels. So there's multiple aspects to health that we're starting to have more visibility of that can consequently lead to an elevated cholesterol level. So in my patients, if they're coming in with a very high cholesterol, I do 2 things. So first of all, we have a look at the triglyceride to HDL ratio. We want to determine, is this atherogenic, artery clogging, or non-atherogenic? And number 2, I still want to find out why it's high. Is there some underlying pathology that we're missing that we don't have visibility of? For example, I've seen high cholesterol in people with mold exposure. Not what you'd expect, but when we actually have a look for antibodies against mold in the blood, we see they're sky high. And when we address the mold issues and we say, oh, okay, well, I've been exposed, I've had a water leak in my car, I've just ignored that moldy smell, get a new car. And over a period of months, the cholesterol, without doing anything else, will just come back to normal. So there's multiple possibilities, multiple potential causes for these things. And I think rather than being in one camp, we're saying, oh, all cholesterol is fine, or, all cholesterol is bad, everybody needs a statin. I think the truth is somewhere closer to the middle.
Yeah, I totally agree.